So today we'll be talking about the common lesions in the head and neck. Actually, it is face and orbit and neck. It's not part of the study. Anyhow, this is the lateral view of the neck, and you can see this is the trachea, air in the trachea, so it's a tube-like, and behind will be the esophagus. So the true vocal cords is it's a lighter band, gray like you see, and the epiglottis is also a gray one, but very thin structure. You see here, the gray one. But I would like you to concentrate on the epiglottis, that when it gets infected and becomes thickened, so it will be as thick as this. You see, this whole is epiglottis. This whole is epiglottis. So it's almost like a thumb. And that's why sometimes it is also called thumb impression sign. So it is the typical sign of the epiglottitis. Okay. So we will move. I will always say next, and you will understand that. Next slide. So if you look at the lateral view again, you can see the air passing through the nasopharynx and then oropharynx and then going into the trachea. And you can see the space, how much it is at the nasopharynx level. But when there is problem like adenoid here, the adenoids are thickened, then it will push the trachea, and you can see if you compare with this, how narrow it is, constricted airway. So this is because of the adenoid mass, and sometimes tonsillar, time tonsils, when they are enlarged, they can also give similar appearance.
I said trachea, but it's not trachea actually.
Oh. Now, if you look at I should have shown you, let us see the normal trachea first. This is the normal trachea. This is how the size is. And you look at the trachea. So here it is very narrowed because it is compressed by a structure which is anterior, and you can imagine what structure it can be. So it's a large thyroid gland. So the patient is having goiter. Now, if you look at, which was actually the same on our right side in the previous one, but I didn't show.
Is there any problem, doctor?
Yeah, I don't know why it stopped.
Okay, can you leave the slide and try it again?
Was
Try
actually
to.
the same
No,
on our right
it's
side
gone.
in the previous one, but I didn't show you. This is the trachea, okay, oropharynx and trachea. But behind that, there are some structures. This is hyoid bone, normal one. These are the calcifications.
As soon as I
of the thyroid cartilage, which is also normal, but there is a linear structure, like as if a needle or a thin bone or whatever. So this is a foreign body which is swallowed, and not only that it's swallowed, but it's stuck there, and it has got some infection. Even you can see bubble of airs. So you can suggest that there may be even an abscess, but the major thing is that you found out that there is a foreign body. And children usually they can swallow sometimes small toys, sometimes coins, sometimes I have seen a case the mother's earring one child has swallowed. So in this case, which is from the net, you can see that there is a small coin swallowed by the child, and you can see that it is behind the trachea, so it is in the esophagus, the cervical esophagus. Now, this is the coronal CT reconstruction of the face at the level of the nose, of course, where there are sinuses. So you know that this is frontal sinus, and these are the maxillary sinuses on both the sides, superior orbital wall and inferior orbital wall. And the drainage of the sinuses, like in this case, I'm showing you the maxillary sinus, that it drains into the hiatus semilunaris, and it goes below the middle turbinate to the middle meatus. So it drains into the middle meatus. Now let us suppose that there is hypertrophy of this turbinate because of inflammation. Usually you can see in allergic rhinitis people, their nose is running all the time. So if they are enlarged and then there is no drainage, what will happen? Stasis. So stasis will cause anywhere there is stasis, like you can take the example of common bile duct when it is blocked due to a pancreatic mass lesion or stone, it can cause stasis, and stasis can lead to infection. Okay, in the ureter, for example, it can lead to infection of the kidneys. So here, the stasis, if stasis occurs, it is blocked and there is no drainage, then what will happen next? Now, this patient is having mild fever and he's having headache, and his right cheek is tender. So we do this Waters view, and you can see that the left maxillary sinus is very well aerated, normally aerated. But on the right side, the upper part is aerated, but below in the lower portion, there is not only opacity, but also a sharp line, which means that there is air fluid level. So this is the typical sign of acute maxillary sinusitis. And in this patient who was having also similar issues, but on both the sides of the cheek, both cheeks were tender, and you can see that the maxillary sinuses, sorry, the frontal sinuses are normally aerated, and you can see the difference in the structure. You see, as I told you in the previous lecture, that all the patients are not having similar structures. This is also normal, and this is also normal. So this is the nasal septum. You can see the bony part and the cartilaginous part. So what's happening in both the maxillary sinuses? There is fluid, air fluid level, air fluid level. So acute maxillary sinusitis bilaterally. Okay, so this patient is having bilateral acute maxillary sinusitis. Now, we have seen in the previous lecture that this is the bony part of the nasal septum, and this is the cartilaginous part of the nasal septum, and the perpendicular plate of the ethmoidal bone, which is behind, and you can see that and this is vomer bone. Okay, that's also part of the nasal septum, and this part is the cartilage. So when there is trauma, whether it is assault or uh, what is that, sports trauma or fall down, you will have fracture. Now this schema also is very good. It shows you very nice diagram of the nasal septum. You can see the perpendicular plate of the ethmoidal bone, the septal cartilage, the nasal bone, frontal sinuses, the ethmoid cribriform plate, the sphenoidal bone, and the sphenoid sinus, which is aerated on the lateral view. You can see very well in other slides, as previously also I have. So on your left is a normal nasal bone, normal nasal septum. But on your right side, now you can easily diagnose that there is a fracture of the nasal bone. Okay, next. Now we don't do CT for the nasal bone fracture because as you saw on the plain X-ray, it is very nicely seen on the lateral view. But sometimes the patient has other traumatic issues like they want to rule out brain hemorrhage or mm, other fractures in the skull. So we do CT scan. This is just a selected view, mid-sagittal view of the CT sagittal, mid-sagittal plane, and it shows you fracture of the nasal bone. So let's revise a bit of the anatomy. That again, you have the sphenoidal bone, sella turcica, dorsum celli, and this is sphenoidal sinus. You see mild mucosal thickening is there, and part of the frontal sinus you can see here. And this is the, you remember the hard palate, what was that? The palatine process of the maxillary bone. Okay, of course, the cervical spine. So next, okay, Lefort was a French army surgeon in the north of France, city called Lille, and he did multiple experiments. Actually, it was on cadaver, but he classified, and up till now, he died, I think, in 1951, but up till now, his classification is famous and is accepted by the whole world. So this fracture of the face involves, you see that it's horizontal and it involves only the maxilla. Okay, so this is type 1. And then there is type 2, which goes and you can see that involvement of the orbit and nose and the rest of the structure. But the type 3, this is the least severe and this is the most severe, the type 3. The type 3, you can see that it involves this portion of the face. And next, now this is the guy, René Lefort in French actually, René Lefort. And we in English, we call it Lefort. Lefort fracture, so type 1, type 2, type 3, among the most severe facial fractures from type 1 least severe and type 3 the most severe, as it is written here, progressively severe category from 1 to 3, and separation either partial or complete of the maxilla from the remainder of the face. All extend through the posterior face, transecting pterygoid plates. So next, a combination of Lefort 1, 2, and 3 patterns can occur on the same side of the face of the patient, but the Lefort fractures are not always bilateral and symmetrical. And the entire face is moving freely in rotation in relation to the skull base. That's why this is very severe type of the facial fracture. Now, if you look at the CT scan of the face of this patient on the left side, which is normal, the superior wall, medial wall, lateral wall, and the inferior wall. And if you look on the opposite side, a bone fragment has gone down. You'll see in another slide, a better one. The fragment is very well seen. So here is a fracture here. And this fracture, if the fracture bone, it goes out, this is called blowout fracture. If it is depressed, goes in, that's called blow-in fracture. Okay, so don't forget that. And in this patient, some of the soft tissue is also protruding into the right maxillary sinus, but there is no bleeding. There's no bleeding in this maxillary sinus. Next, this is the same patient. Continuation of the previous. So you can see the normal side, and this is the maxillary sinus, sphenoidal sinus, frontal sinus, part of little bit mucosal thickening there, and the inferior portion of the right orbit, which is depressed. So this is blowout fracture. So again, a part of the anatomy, and this is the CT coronal reconstruction. You can see the frontal bone, superior margin of the right orbit. This is the left orbit, part of the frontal sinus on the left side, alveolar process of the maxillary bone, the medial wall of the orbit, which is partly formed by the lacrimal bone, and the nasal septum, which is formed also in the posterior aspect by the perpendicular plate of the ethmoid bone, as I showed you on the plane X-ray, that you cannot see it very well on the plane X-ray. So on CT, you will see very well. Next, this is a bit more forward plane, and too many structures actually, and some of them I have removed because you don't need it. But these all all these structures, maxillary sinus, ethmoidal cells, and the cribriform plate, the crista galli, and the superior margin, inferior medial margin, etc., etc. You will see it when you are revising it. So next, again, a CT of the uh, coronal CT of the maxillary sinus level. So what do you see now? Actually, if we were in the class, then we could discuss it better. But if you look at on your normal side, on the right maxillary sinus, there is minimal mucosal thickening here, but there is nothing else, no air fluid level or sinusitis or anything else. Nasal septum is also okay. The ethmoidal cells are not opaque. Little bit opacity is here also. But if you look at on the left side, it is opaque. There is some structure here. And since these are bone windows, you don't see better the soft tissues. Actually, this is a bit denser than what you see. So there is blood, hemosinus on the left side. And you look at the bony structure, then you might have definitely seen that there is fracture here, and also part of the orbit that you see, there is also a blowout fracture. So you can see that part of the bone is out of the orbit and is gone inferior. So there is a complex maxillofacial orbital fracture which contains also a blowout fracture. So this is a complex fracture, okay, with hemosinus. Okay, next. So town view, as I told you, you don't need to remember the names of the views, but the tech, he will do a town view, but because you have requested in this case that history of trauma and the patient is having pain on the posterior aspect or in the occipital region. So the tech has done AP, lateral view, PA and lateral view, but he add this because in this case, the occipital bone is very nicely seen compared to other views. Okay, so if there is any fracture, you will see here. Surely these days now we do a lot of CTs, but there may be places or in ordinary clinics with where they still do the plain X-ray, and you have this coronal suture and lambdoid suture, which separates the parietal from the occipital bone. Okay. So this uh, picture of the mandibular bone, it shows the frequency of bilocation of the mandibular fractures. The least one is of the coronoid process, and the most frequent is the condylar fracture of the mandible. This is the ascending ramus. And also, there is very few fractures on this because this is very thick, hard bone. And then the rest is 25% at the mandibular angle and at the body and at the parasymphysial ventral region. As you can see here, 15%, 20. It depends on type of the accident, like car accident, you may have these fractures. Now look on this slide on your left. You, as you saw the image, the previous uh, slide, this is mandibular, the mandible of the, sorry, the mandibular condyle of the mandible. And then you go like this. So I will start from here. You can see. So this is the coronoid process. This coronoid process, you will rarely see any fracture. Up till now, I've seen maybe a couple of fractures, but most of the fractures I've seen here. Okay, so this is very important. You must know all this. So again, angle of the mandible and body and mentum. So in this case, the arrow is showing you, but if you look at the ramus and part of the condyle, you can see here. Here you can see very well the condyle, and at the base of the condyle, there is fracture. Okay, so now sometimes it is difficult. The patient has severe trauma and we cannot move him and he cannot open the mouth. Sometimes we need it that he should open or close. And so in difficult cases, we definitely do CT scan. These are multiple uh, slices of the opposite side of this patient. You can see the temporomandibular joint. This is temporal bone and this is the mandible. So temporomandibular joint. So on the opposite side of this patient, he is not only having fracture, but also dislocation from the joint. So this is temporomandibular joint dislocated fracture. So fracture dislocation of the mandible, mandibular condyle. Fracture dislocation of the mandibular condyle. This is very important. On your left side, you have seen this slide many times, frontal bones, zygomatic bones, greater wing of the sphenoidal sinuses, ethmoidal air cells, and this is what is this? Nasal septum. On this side, they are not aerated. They are not as dark as this because, as you know, on CT the airways look dark. They are opaque. So there is mucosal thickening, there are secretions, so there is inflammation. So this patient is having sinusitis of the ethmoidal cells. Definitely he will be having another slices. Other sinuses may also be involved. Okay, next. Now this patient, this maxillary sinus is okay, very well aerated, no mucosal thickening, no air fluid level. But in this case, there is no air fluid level, but significant severe thickening of the mucosa all around the sinus. So this is a very typical sign of chronic sinusitis. So this is chronic maxillary sinusitis. And if you look at the bone, the walls of the maxillary sinus, there is more denser because there is reactive sclerosis, long-standing sinusitis. So there is a reactive sclerosis of the maxillary sinus wall. Now the left maxillary sinus is opaque, the right is normal. Look at the frontal sinuses, they are normal. So it may not be only sinusitis, it may be tumor. So you are not supposed to say straight away tumor. Of course, if he is young, 15 years, 20 years, 30 years, you can say sinusitis, but sometimes there are tumors, especially in elderly people, 40, above 40 years, you have to be careful. Next. Now, just this one to show you normal maxillary sinuses on another view. And the, what is this, you remember? Zygomatic arch, okay? Zygoma or zygomatic bone and okay, this 3-year boy, he is having headache, and the patient, the he was brought to the hospital as the physician requested an X-ray, and you have a lytic lesion. You see, dark area. This is normal areas, but here lytic destructive lesion. So in children, lytic lesion in the skull, the first diagnosis, and I would say the only diagnosis we should suggest, is Langerhans histiocytosis. It is written here down on in the notes, you will see. It is elderly, either if it is one or there are multiple. So we have to think of other things, like this patient was having multiple myeloma, but let us say this is a female and she is having CA breast. So this will be, yes, metastasis. Okay. Now this patient is also having inferior terminal enlargement, so she must be having allergic rhinitis also. So quickly revise just few things. What do you see? You saw normal, you saw air fluid level. So acute maxillary sinusitis on the right side. Left is normal orbit, the right orbit, a big fracture piece you can see, but there is no hemosinus. So this is blow in or blow out fracture of the right orbit. Good. One, you have seen it. Fracture of the condyle. If I ask you whether it is fracture dislocation or only fracture, so you will say fracture dislocation. But if I ask you, is it normal or is there a fracture? So you will say there is fracture. Where is the fracture? Mandibular condyle. So I repeated it multiple times, the structures. What are these structures? You should know it, okay? Okay, so I don't know why it came again.
I think we are done.
Done, doctor?
Yeah, any question? How do we describe? Just say that fracture of the mandible, mandibular condyle. We say air fluid level. Yes, we do say air fluid level. For the last picture that was shown, yes, this is air fluid level. You see, it is how sharp and straight. So this is because of the fluid. If it was very thick mucosal thickening, it will not show sharp line. It will be irregular, thick mucosal thickening. How do know air fluid level from mucosal thickening? As I told you, air fluid level will be sharp and straight, and mucosal thickening will be irregular and not usually straight. Oh, hold on, what is saying? Doctor, can you show ethmoidal air cells again? Oh la la. Okay, we will see later on. Difference between blow in and blow out. Actually, blow in is rare. The fragment will go towards inside the orbit, and you saw that it is going outside the orbit, so it's called blowout fracture. Yani below the orbit, like hanging, the fragment is hanging, so that is blowout fracture. For the last picture, that's okay. If there is a fracture in the floor of the orbit and there is blood in the maxillary sinus, it's traveled to the nasal cavity as well, right? Yes, it may. If it is enough. If there is little one, it will stay in the maxillary sinus. Okay. Hold on, I'm showing you somebody asked for ethmoidal cells. These are the ethmoidal air cells. The person who asked for ethmoidal air cells, these are the ethmoid air cells on both the sides of the nasal septum. And this is the sphenoidal sinus. Okay.
Is that all? Thank you, doctor.
Okay, any more question?
No more questions. Thank you, doctor.
Okay, thank you, bye. Take care.